So good afternoon and welcome to the European Stigma and Discrimination Forum. It's a great pleasure to welcome you who are here in person and those of you who are here virtually as well. Can I have the next slide, please? So I'm the program director, Mark Nelson. We have two co-chairs, Vanessa and Memory, who are actually going to lead you through the program. You can see before you here. You'll notice there's a large number of UK speakers compared with the broad range of European speakers that we'd like. That's because we only have 2 weeks' notice to actually put this program together, and a lot of people couldn't make it or had already booked their flights. So I'd like to thank everyone who is a part of the faculty, particularly those people who have stepped in very much at the last moment. Next slide. These are some practical tips. I'm sorry I'm not reading them out, but I can't actually see them. It's all a bit of a blur for me, but these are the practical tips if you are dialing in virtual line and you are able to submit questions to the chairs. Now, we've run a lot of these forums. These forums have been run globally, but they've been concentrated really in lower middle income countries. And so it really is good news, I think, for people to recognise that this is a global phenomenon, that stigma and discrimination is really what is holding us back from going even further than 1990. And as you see, we've run these globally, including in the Middle East. And I'm saying in the Middle East because I think that one of the highlights of these meetings was really the fact that in the Middle East, when Bruce Richmond was talking about U equals U and put up a list of countries, and a gentleman from the Saudi Arabian government put his hand up and said, "Why aren't we on there? We believe in this and we sign up now." And I think it just shows that perhaps us all could do with actually decreasing stigma and discrimination to a whole load of factors, not only to do with HIV. Next slide. You know, we can't put on this forum without the support of ViiV, and ViiV have been really fantastic in their support in that they've funded these meetings and had no input at all. So all they do is give us the money and let us get on with it. I'd like to thank everyone at ViiV. I'd like to really thank one person, especially Natalie Dang, who's based in Asia, who's really put herself out there and saying, yes, there is a problem in this area and it's really important to us. There's also a wide range of endorsers you can see here, both globally and from the UK, and we'd like to thank them for their endorsement of these meetings. Next slide. Please, please, please fill out your feedback form. I know after the meeting everyone's a bit tired, but you can put these in virtually. You'll then receive a certificate of attendance. And of course, it's really important for us in moving these programs forward, improving them, and looking back at what has gone wrong and what has gone right. So please, please, please do fill out these forms. Next slide. Now I'm going to hand over to my co-chairs. I'd like to thank them very much again, Vanessa and Memory, to introduce the opening lecture. Thank you very much.
Thank you, Mark. First and foremost, I'd like to welcome everyone in the room today. Thank you for being here. I'd also like to welcome our virtual attendees who are all over the place and all over the world. As Mark has said, please make sure you send your questions through the portal. We'll be looking at those. So our next speaker is Mark Angel, who's the MEP based in Luxembourg. He's agreed to do an opening welcome for us. Video, please.
Dear organizers of the European Stigma and Discrimination Forum 2022, dear all, I would like to thank the program chairs, Professor Mark Nelson, Ms. Memory Sachi-Konye, and Dr. Vanessa Apea for inviting me to the European Stigma Discrimination Forum 2022. Unfortunately, due to other obligations, I'm not able to take part physically in this event, but I'm glad to have the opportunity to take the floor today through this video message. First of all, I would like to present myself. My name is Mark Angel. I'm a Luxembourgish member of the European Parliament for the Socialist and Democrat Group in the European Parliament since 2020, and I'm the co-chair of the LGBTI Intergroup. This is the biggest intergroup in the European Parliament, counting 156 members of the Parliament. They are not all LGBTI persons, but they are important allies. In my capacity as co-chair of the LGBTI Intergroup, I have the honor to work closely with civil society and policymakers to improve EU laws to better protect our community. You're probably aware that last week 2 young Slovakians have been killed due to their sexual orientation. We've managed, with the involvement of most of our allies in the European Parliament, to get a debate in the plenary, but also a resolution condemning this horrible attack and calling for concrete actions, such as the inclusion of the hate crime and hate speech to the list of EU crimes, the ratification of the Istanbul Convention, the unblocking without delay of the horizontal anti-discrimination directive, and finally, the call for a rapid adoption of the so-called gender-based violence directive. This is an example of what we do as an intergroup in the European Parliament to promote and defend rights of all people in all their diversity. When it comes to HIV/AIDS, I've personally witnessed the impact of the AIDS pandemic on people and friends. I have experienced the barriers posed by human rights violations, stigma and discrimination and inequalities. I've also observed the positive contributions by civil society and community organizations being much closer to the realities faced by people living with, at risk of, and affected by HIV. And this is why I co-founded Stop AIDS Now, Luxembourg, earlier in my career. In the fight against HIV/AIDS, we have come a long way, and we made a lot of progress. Yet, in my current capacity as a member of the European Parliament and co-president of the Intergroup on LGBTI rights, I am confronted with serious human rights violations within the European Union and beyond. We must step up genuine engagement and leadership of communities and inclusion of key populations. In 2019, funding for the HIV/AIDS response in low and middle income countries was 30% less than the the $26 billion which the UN member states committed to mobilize by 2020. And in the past decade, low and middle income countries increased their HIV domestic resource allocations by 52%, representing the main source of funding for the fight against HIV/AIDS. In the same period, the share of HIV/AIDS funding from other governments, except the United States of America, has decreased from 11% to 2%. Moreover, countries were insufficiently able to address the societal and structural barriers to enable an effective response. Falling short of the agreed commitments resulted in an additional 820,000 people dying from AIDS-related illnesses, an additional 3.5 million people acquiring HIV, requiring a lifelong antiretroviral treatment. One key lesson learned from the HIV/AIDS response is that investing too little and too late has a huge cost for humanity, with millions of additional people requiring services, straining often fragile healthcare systems and yielding more costly responses. The European Parliament, under the leadership of the Parliamentary Committee on Development, has been closely involved in this process through its resolution on accelerating progress and tackling inequalities towards ending AIDS as a public health threat by 2030. The resolution calls on the European Commission to address AIDS as a global public health crisis and accelerate all efforts to meet the 2025 targets, including through scaling up investments in UNAIDS and the global funds to fight AIDS, tuberculosis and malaria, among others. Inaction has a cost. Each year, the world fails to fully fund the HIV response, at least 360 billion, or lost because of the economic cost of homophobia due to stigma and discrimination, lost productivity due to avoidable AIDS deaths, and lifetime costs of HIV treatments from avoidable new HIV infections. while adequate HIV/AIDS funding has become even more precarious in view of the earlier COVID-19 crisis and now the Russian invasion in Ukraine, the consequences of not investing in ending the AIDS pandemic are dire. We cannot allow for a worsening of the HIV pandemic. A second key lesson is that intersecting inequalities such as social, economic, racial and gender inequalities and restrictive social and legal environments continue to drive the HIV/AIDS pandemic. The people being left behind are those who disproportionately experience gender inequality, HIV-related stigma, social marginalization and criminalization. The third lesson on the centrality of a human rights-based approach to create an enabling environment for successful HIV/AIDS responses and affirm the dignity of people living with or vulnerable to HIV so that the world defeat AIDS by 2030. Despite being more than 40 years into the HIV/AIDS epidemic, continued human rights challenges, including stigma and discrimination, misuse of criminal law and punitive approaches, mandatory testing inequality, and violence against women and girls, and denial of sexual and reproductive health and rights remain among the main barriers to effective HIV/AIDS responses. For example, 60% of the countries that report to UNAIDS still criminalize HIV exposure, non-disclosure and transmission. 37% criminalize same-sex sexual relations, and 40 countries still retain restriction on entry and stay for people living with HIV. Also, stigma and discrimination remain major issues. More than 25% of people aged 15 to 49 years reported holding discriminatory attitudes towards people living with HIV, as shown by recent population-based survey data. It is for this reason that Luxembourg, my home country, a strategic partner of UNAIDS and a member of the UN Human Rights Council, has committed to join the Global Partnership for Action to eliminate all forms of HIV-related stigma and discrimination as the first EU member states, and I hope all the others will follow. In my role as UNAIDS Red Ribbon leader for the 10-10-10 targets, I commit to utilizing my expertise, my experiences and networks to advance the achievement of the 10-10-10 targets within the European Union and EU partner countries in close collaboration with and under the guidance of UNAIDS. I'm excited to support both the Global Partnership Against HIV-related Stigma and Discrimination and the Education Plus initiative as critical vehicles and amazing opportunities for achieving the 10-10-10 targets. I wish to all of you a fruitful forum full of successes and good discussions. Thank you very much.
Thank you, Mark. Our next lecture comes from my co-chair, Vanessa, up here, from BATS in London, and Queen Mary. There's a slide clicker somewhere.
Perfect. So what time are we now? So good afternoon, everyone. It's lovely to be here, and I'm really glad that we've got this time together to talk about something that is so important. And really, I think when we come together and reflect about what we can do better, I think that's when change really happens. So I'm going to talk about stigma and discrimination in Europe. First of all, just reflecting about stigma and exactly what we talk about when we think about stigma. So stigma is a complex social phenomenon, and there are many definitions of stigma, but one of them involves distinguishing people based on social statuses such as attributes, illnesses, and identities, and socially devaluing, discrediting, and excluding individuals with those statuses. And we know, and why we're here, is that HIV remains a highly stigmatized but also misunderstood health condition, and it undermines all we do within the sector and is one of our greatest challenges. And for me and for many of us here, I'm sure we all agree, is that it is a clear social justice issue. And when we think about stigma and we think about the ways in which it manifests, there are many different frameworks. But when we consider it, we need to think about internalized stigma, interpersonal stigma, organizational, societal, and also public policy as well. Now, HIV disproportionately affects those groups that are typically stigmatized in society. And when we think about stigma, it's really important that we recognize the socio-structural factors and the social determinants of health that impact both HIV transmission and also HIV-related stigma. And we can't help but recognize that HIV-related stigma is closely related to societal power structures and frameworks. And often in an individual, there are intersectional stigmas. So essentially, there are multiple stigmatized identities that are present in an individual that intersect and overlap and become multiplicative in their impact on that individual. And it's recognizing these intersectional stigmas that are crucial in our management as well. So I'm going to talk about London's response to exploring stigma in HIV and then move on to a wider European experience as well. So the City of London made its commitment clear to be one of the first cities, or the first city globally, to get to zero. And one of the greatest challenges is stigma. And so the Fast Track Cities London spearheaded a systematic collaborative approach to tackling stigma. And I'm speaking on behalf of many colleagues, some here today, that have been part of this stigma subgroup. And it was obvious that there was a clear need for impactful interventions that would make a difference. But to do this, it was crucial that we needed to understand where we were starting from to co-design these initiatives. And so when thinking about this path to achieving zero stigma, it was clear that there was a dedicated action plan that was needed to be informed by real-time evidence. So what was the response? Well, in early 2019, dedicated funding was identified and a stigma working group was formed. And first of all, there was a pragmatic review of the evidence to date to inform the work that we were going to do. And then there were 3 key areas of focus that were proposed. So thinking about internalized stigma and how that was going to be approached, stigma within the NHS and other public services, and societal stigma. And I'm not going to talk about the other features, but they're really important and fantastic work that's been happening. So related to internalized stigma, there was a creation of an empowerment program which had been shaped by a community of practice. For stigma in the NHS, we're in the midst of developing a HIV-friendly charter, but I'm focusing on the societal stigma response, which was to commission a survey to set a baseline on public knowledge and attitudes to HIV. And this is just an outline here, but just to note that we started in early 2019, but we're all very aware of what happened in between. COVID did impact the timing, but I'm happy to say that in January 2021, the National AIDS Trust and Britain Thinks were commissioned to develop this survey, and the results were published in July 2021. Here it's over there. And so in terms of the methodology, it included a number of community stakeholder consultations, exploratory focus groups, the survey itself, and then follow-up deep dive focus groups to reflect on the insights that were given. And so just thinking about some of the key outcomes, over 6 in 10 reported not having heard anything about HIV in the last 6 months. And when people had looked at that, they reflected on TV programs, social media, online news, etc. But they were most likely to have not heard anything in the last 6 months were those that were aged 65 and over, non-Londoners, white and South Asian people, and those in rural areas, amongst others. Another key outcome was that only a third of Londoners said they had sympathy for people living with HIV, regardless of how they acquired it. And so people felt that if they were going to have more sympathy for people living with HIV, were those that were LGBTQ, or those that personally knew someone with HIV, Black people compared to white and South Asian, and women compared to men. And another feature that was reflected within the survey was public awareness of U equals U. So public awareness was low, and with a majority still believing that it was false and that effective treatment prevented transmission. And for many of us here, and we're going to be reflecting about U equals U in a follow-up discussion, but it's really a strong reminder that within our sector, we do a lot about reminding about U equals U. We have many discussions about it, but the key is that do wider society, are they aware of it? And the survey suggested not. As I said earlier, and as is reflected here, and as when we're thinking about the outcomes of the survey, HIV stigma is complex, but three key themes emerged from the survey. So themes that the perception that acquiring HIV is associated with quote-unquote taboo behaviours, including condomless sex, promiscuity, and intravenous drug use. It was clear that there was a low knowledge of transmission, treatment and outcomes, and there were persistent negative attitudes towards the LGBT community who were closely associated with HIV. And following on from this survey, across Europe, a follow-up survey has also been done, and I'm pleased to say that I've got the honour of presenting some of the preliminary results, and these are really hot off the press, and they were just presented at EACT's Standard of Care meeting last week. But the European Centre for Disease Prevention and Control, European AIDS Treatment Group, AIDS Action Europe, together with the UK's National AIDS Trust, which worked on the UK survey, commissioned the first ever European-wide HIV stigma survey. And this was exploring the experience of stigma amongst people living with HIV across Europe and Central Asia. And so what were the key insights? So first of all, this survey was carried out between November 2021 and January of this year. And there were over 3,000 responses from 54 countries. And when we look at the breakdown there, we had 80% men, of which 0.5% were trans men, 16% women. Of these, 17% were trans women, 3% were non-binary or identified in some other way, and 1.5% did not respond in terms of their gender. And 68% identified as lesbian, gay, or bisexual. And when we look at some of the preliminary results, the overarching outcome for me is that people living with HIV in Europe are as likely to have experienced stigma in recent years as a decade ago. And this is particularly in healthcare settings. And it really raised the concept of anticipated stigma. So, and this is a distinction that someone can perceive stigma, someone can experience stigma, but also people can anticipate it from previous negative experiences, will think that they are going to be experiencing stigma. And actually, that anticipated stigma can be as powerful as experiencing stigma in itself. And then when people were questioned whether they were ashamed of their HIV status and if they had low self-esteem because of their status, 27 to 28% of people agreed or strongly agreed with both questions. And 40 to 49% disagreed or strongly disagreed with them. And there was also a concept of isolation which came through, in which 17% of respondents saying they had not even told one friend about their HIV status. So as we advance to zero, it's really key that real-time evidence is so important to really recognize that stigma is prevalent, but also to give us insight into the key drivers that we need to tackle as we need to step into action. And it's really translating the key learning from these stigma surveys into an action plan to mitigate or eliminate stigma. And I think that all of us will really also agree the importance of coming together for defined metrics of success. And some of these may be, in terms of our next action, could be with healthcare provider surveys and the charters that I've mentioned previously. But two of the key themes that have come out of this and are the sources of our focus and reflection today is the use of language, and the use of language amongst ourselves and wider society, and also the importance and power of the U equals U messaging, but also reflecting on both the positives and negatives of that. And I'm really happy to say that we've got great panels today that we're going to discuss, reflect with all of you here today, with all of you virtually, to think about what we know, to think about what we don't know, and think about what we need to do next. So as I end here, I want to really acknowledge the Fast Track Cities Leadership Group and the Fast Track Cities Stigma Subgroup, all that are highlighted there, and the National AIDS Trust and Britain Thinks, who commissioned the survey. Thank you all so much.
Thank you, Vanessa. We have about 5 minutes for questions, immediate questions, comments. I'm also checking online. Anyone with questions in the room? Yeah. Would you introduce yourself when you get the mic? The mic is coming to you.
Is it morning or?
Yeah, I think we've agreed it's afternoon.
Okay, good afternoon, everyone. My name is Elizabeth from Stichting Max Factor in the Netherlands. Yeah, and my question to you is, what is this organization going to do to help the remote part of the Netherlands that is called Groningen, where I come from? And there's so many things that you've talked about, like isolation, sympathy, and stigma in healthcare is there. I have experienced it because I came to Europe, I gave birth here, so I have experienced a lot of things in the healthcare setting. So now you're talking about it, and let's come up with also solutions. After talking about it, okay, it's there, it's happening. What are the solutions? Where I come from, like in the north of the Netherlands, even HIV, like even the person I was married to, when I told him I'm HIV positive, he was like, eh? He started crying because he has never heard of that. He told me, I hear that, but I hear it in Amsterdam with gay people. You see, something like that. So the, what do you call it, awareness, where I come from, where I'm working right now, is not there. People don't even know about HIV too much. HIV is really known in Amsterdam only. And people are talking there aloud, you know? So help us set programs there, help us change the situation there, and that's all I can say. We'll talk more later. Thank you very much.
So, yeah, so there's the clap. So first of all, thank you so much for openly sharing, and also thank you for coming, because I think this is why we have the forum such as this, to bring people together from all across Europe, and not just focusing in the capitals, so not just focusing London, Glasgow, Amsterdam, etc., but making sure that we're getting the links from representatives from all across Europe, whether the terms that we're going to use, urban versus rural, but making sure we've got that wider perspective. And I think you're so right. I think that it's important for us to state what stigma is and to have these surveys to have a baseline, because, you know, like it or not, if we are going to be working with politicians, policymakers, other people within sector who have no concept of HIV, we have to show them, we have to have evidence to say this is a problem. So I think what we can say is that we've got clear evidence that it's a problem, but now we have to think about what we do together. And what I'm really hoping is that through the conversations that we're going to have today, we're not going to have all the solutions, but we're going to raise awareness. We're going to start to think about, for example, you are best placed to say what would work best in your context, in your locality, and also for us to share ideas, and also for you to say what you would need, what support you would need to make change in your area as well. And I think those are the types of conversations that we need to have, because I completely agree. We need to move from stating to us the obvious, and then actually how are we going to do this? Because 2030 is, you know, it's a goal that we can all work to, but it means nothing without action together. So no, completely agree. Thank you.
Thank you, Vanessa. I think the next question, which is, there's a question online, but I think it will be addressed as the day goes on. Somebody's saying, you know, how do you help clients with internalized stigma get over it? So it's something to think for everyone during the day as you do your presentations and the panel discussions. So that will come through. So I think, thank you.
Yeah, no. Any other questions at all?
We just have 2 minutes. Last question.
Actually, I'm Edith from London. No, it was quite shocking to hear that people are still experiencing stigma as they did 10 years ago, one point of your survey, and another section that people haven't heard about HIV for 6 months. Yeah. So it shouldn't just be in the HIV Awareness Week that the media or local places, you know, should talk about HIV. I think it should be a normal conversation throughout the year. And as well, healthcare workers, lack of knowledge is letting them sort of discriminate, which is maybe a subconscious, unconscious attitude. So like conferences like this will increase awareness so we can all take something back and educate ourselves, really.
No, thank you so much. And I think those points, I'm sure, you know, resonate with everyone. And I think for me, when I was looking at the highlights of the European survey, it's that decade that really stuck out to me because, you know, we talk about 40 years of the HIV epidemic and, you know, moving forward and development. And then actually you've got something really stark there that we've made a lot of advances, but there's a lot of deep-seated misunderstanding that is still there, similar to a decade ago. And so how do we push forward with that? So yes, completely agree. And I think, you know, we're going to talk about the healthcare workers and what we can do, but it is about raising awareness as we're doing, but again, translating into something that needs to change, definitely. So yes. Oh, okay. I'll be quick in my response.
I'm Rosalind from Germany, and for some of the solutions, I think it starts from you as a person in your community, because this is at the European level. It starts in the Netherlands, and you can raise your voice, try to network, because there are people. I know somebody that is very powerful, stigma, HIV and stigma fighter, Elaine. She's not in the conference today, but she is so powerful, and she's in the Netherlands, so I think she will be very happy to, assist you.
Oh,
thank you, Rosalind.
I think that's a really nice way to end.
It's not about, I didn't speak about assisting me. For me, I can defend myself. But those people who cannot defend themselves, those people who are just new in the country also, those migrants, you know, Eileen, I know her.
Okay, then it's good.
And for you to be open, you need to be trained to come out and to speak about it, and not everybody is comfortable about being open, you know? Mm-hmm. You need to be trained. You need to be ready for whatever discrimination you're going to get from people. So it's not something that you can tell somebody, oh, come out and say you are It can't be like
Okay,
that.
I think
but
we
for
need-
somebody who wants to be open, it's fine. But somebody who does not want to be open, how do we help them to live comfortably where they are?
Can I just answer that? I mean, as a woman living with HIV for 20 years, I got the support, the peer support that I needed to be able to be confident in myself, to openly say I'm living with HIV. So I do agree there's a lot of learning and supporting and empowering people to be living openly with HIV and be able to defend themselves. So that's a plan or a program that might need to establish in your area. And I think on that note, we need to end this session.
Thank you. And I was just going to mention that the communities of practice and empowerment the Fast Track Cities are doing. I think it would be great if colleagues here that have worked in it would share with you as well, because I think it is about collaboration and learning. But thank you all so much. Thank you.
Moving on, we are now going to start to go into the first session of the day, which is going to focus on language matters, how to communicate in a non-judgmental way. And our first speaker is Jo Smith. Jo has been a specialty registrar at the GM Clinic and HIV at the Chelsea and Westminster NHS Foundation in London since 2019. They have conducted research into topics such as perceptions of HIV risk and PrEP, acceptability in transgender and non-binary people, antiretroviral and gender-affirming hormone therapy, drug interactions, and domestic and sexual violence in the LGBTQ+ community. Over to you, Jo.
Thank you. Thanks very much, everybody, for inviting me and for coming to my talk. The title that I was given for this was, How do you ensure communications with your clients are stigma-free from a healthcare provider's perspective? And that made me think, how do I ensure that my communications are stigma-free? Does anybody? Is that even possible? It made me reflect on the times that maybe my language hasn't been perfect. I've enacted stigma against people, without meaning to, and I think probably everyone has a little. I think in the HIV sphere, we may be at risk of a little bit of Mother Teresa syndrome. We think we're the good guys. We couldn't possibly cause anybody any harm. We help AIDS patients when no one else would. I think that is a little bit of a dangerous thing to be so complacent, and I think we all need to be sort of vigilant and reflective about how we approach our work. So this is what I'm going to chat about. A very brief overview of stigma theory. From a sociological perspective, a recent case example from my work at Chelsea Westminster, where a patient experienced healthcare enacted stigma and how we managed it, and what we can all do to overcome the burden of stigma-associated morbidities and poor outcomes for our patients. So what is stigma? So Goffman first wrote about this in the 60s. Heard a little bit about it from Vanessa already. The short, the Cliff Notes version is an attribute that is deeply discrediting, socially isolating. And there's lots of people describe it in lots of different ways. You can break it down into concealed or concealable attributes or unconcealable. So HIV status arguably would be a concealable stigmatizing attribute. And people hide, and it makes people very isolated. It makes people very afraid to sort of come out about their status. Stigma occurs at all levels of society. It can be a global or sort of macro society level. It can be regional with sort of politics and policies within communities, particularly within religious communities. Interpersonal, so sort of how you interact with the people around you day to day, and intrapersonal. It's been mentioned already, but if you believe what society is telling you, that you deserve this, that you're a bad, dirty person and you don't deserve good things, you don't deserve good health, you're not going to be able to engage. That's a really, really challenging concept to overcome. So Lincoln Phelan expanded on this theory of stigma, and this is their conceptual framework. And all of these things interlink. You identify and label people in society who are different. You get the in-group and the out-group. and then you stereotype and sort of myths and discrediting ideas start to come out. It's like all the 4 H's of who gets HIV from the 80s, the Haitians, homosexuals, drug users, etc. They feel they get excluded, they get discriminated against, and all of this is working in a framework of power. So you get power and prejudice. So here's my case study, Sally. So picture it, I'm on call, I'm doing a bank shift twilight at the hospital, and I get a phone call from the emergency department nurse practitioner. Oh, hi Joe, I'm glad you're still here. Can you come and see this patient and send her home? She's one of yours. Right? already I'm thinking, this is going to be a difficult one. So Sally is a 34-year-old woman. She's of African descent, but she's been in the UK basically all of her adult life. She acquired HIV perinatally. She has struggled a lot over the years. She has a very complex and traumatic background. She struggles to engage with the clinic. She struggles to manage with her antiretrovirals. And she is what is uncharitably described as an emergency department frequent flyer. Her last viral load was 180,000. Her CD4 count is low. So she's got very, very complex medical background. She's had PCP, she's had infective endocarditis, she's had episodes of drug-related psychosis, for which she's been sectioned, she's detained under the Mental Health Act. She suffers from non-epileptic functional seizures. Again, a very stigmatizing condition. A lot of healthcare workers have opinions about what functional seizures mean. Unfortunately, when she went on her antipsychotics combined with Biktarvy, she gained a lot of weight, and she struggles with that. That's something that we have caused her, and it causes her a lot of low self-esteem in addition to everything else. And one of the commonest things she comes to the emergency department for is abdo pain and vomiting. Sometimes it's a symptom of a flare of her chronic pancreatitis. Sometimes we don't find any problems and she's dismissed as psychosomatic. You're making it up, you're doing it for attention, go home, stop wasting our time. So a bit more about her social background. So she's a heavy cannabis user, she drinks a lot, she sometimes injects IV opiates. And she struggles to have steady employment, and she does sex work to pay for drugs. She's got a very, very vulnerable social background. Her ex-partner's in a gang. She's been involved in gang activity before, and he's beat her up before as well. And she goes back to him, she dumped him, she goes back, etc. Because perinatally acquired HIV, a lot of her family have died, sadly. So apart from a few friends that kind of intermittently provide support, her only living family is her younger brother, who is also perinatally HIV, chaotic social situation. He's got very bad mental health as well as physical health. So she really struggles for sort of support. So where does this nurse practitioner stigma come in? So we've already heard, the nurse thinks, drug seeking, frequent flyer, personality disorder. I hate that label. I think probably in the next 5 to 10 years, we're going to get rid of the term personality disorder because most of it comes from complex PTSD and an understandable but maladaptive response to complex childhood trauma. Functional seizures I've already mentioned, and all this boils down to she's a difficult patient, I've got a busy A&E department, I'm too busy for time wasters like this. So this all comes under, as I said, the power and the discrimination umbrella. So it's compounded by the fact that she's black. She's a black woman, and we know that black women specifically are much more likely to not be believed, think that their pain is being exaggerated, think that their symptoms are being exaggerated, and have delayed or absent management of their symptomatic needs. She's a fat black woman, so we have something that we really don't talk about in the medical sphere enough is fat phobia. And we think, being fat is a sort of a personal moral failing rather than a chronic disease, which we should be attuned to and be supportive of. There's a very tendency to say, your back hurts, it's because you're fat, go and lose some weight. No, we need to provide better support. Compounded with all of that, She's living in poverty, she has poor educational attainment. She's a smart woman. She's had to be, because she's had to learn how to survive in a very, very hostile environment. But because she hasn't got a RP accent, she's working class, and that means she gets discredited and not given the autonomy that she really deserves. And we all know about judgmental societal constructs, about people living with HIV, about injecting drug users, sex workers, around mental illness as well. So what did I do? Of course, I went down to see her, poor Sally, and she said, "Thank bleep, you're here, Dr. Joe. These nurses are being bleeping bleeps to me, innit?" So, bless her. After checking that she was safe enough to leave, so it was, no abnormalities found on her bloods, apart from, we know, the low CD4 count. She's got somewhere safe to go for the night. She's not going back to her ex-boyfriends. I gave her what she wanted in that moment, which was Ensure build-up juice. It's one of her favourite things to drink. And yes, she's overweight, but she has very bad food instability from being in poverty. And that means she's not going to have to worry about finding money for food for the next week. I gave her some Septrin, just a sort of a bridging measure to say, please don't get PCP again. Like, let's negotiate a reason, what's realistic for you to keep you safe in this moment. And I booked her in to see me specifically, named clinician, in the rapid review unit the following day for a review of her blood tests that will have come back from the previous night, and have a little chat about, how do you feel about restarting some antiretrovirals? Do you want to try something else that's not going to interact with your antipsychotics and not make you gain more weight? See how you feel. Let's try and get on a level. She didn't turn up, of course, but I chased her down, eventually managed to get her into the clinic, and we had the chat. So what's the moral of this story? I mean, we have all been raised in societies that have cultural ideas about stigma. None of us are exempt. We're all, we have this in the back of our minds. And it tends to be that they fall along lines of social indices of deprivation, racialization, poverty, chronic disease. And healthcare settings are a significant source of stigma. And what Vanessa was mentioning about the anticipated stigma, she hates coming to clinic because she worries that she's going to be stigmatized. And she hates going to the emergency department because of nurses like that. But she's in crisis. She has nowhere to go. She's not being a difficult patient. She is expressing an unmet need. And we're not going to fix all of her problems. I don't think we ever are. But we try and, take one step at a time and see how we can support her in a realistic way. So what can we do as clinicians, as policymakers, as sort of service directors? I think the number one thing I took away from this was collaborative working and HIV education for non-specialist teams. So we went to the clinical director of the emergency department and said, can we come and give you a teaching session, please, about HIV, about U equals U, about people who are frequent flyers and people with lots of complex unmet needs. And hopefully that's going to start to sink in. Taking a trauma-informed approach, so that's, with the knowledge that people have complex, difficult backgrounds and it's not their fault. I mean, nothing is, people who are struggling with their health and with their mental health, it's never their fault. Realistically, we're probably not going to get her undetectable. We're probably not going to get her CD4 count up, but a harm reduction approach, meet you on your level, have a bit of Septrin, please use some condoms if you're going to do sex work, etc. Please have some clean needles if you're going to keep injecting. We're here to help the whole patient. We're not just a HIV doctor, here's some tablets, off you go. We treat the whole person, and that means looking at their background. We can never achieve it unless we address that. And I would like to think that, I'm not your classical serious doctor in a white coat. You don't get many doctors with green hair. But I think it's a really important concept to show that, I'm not a lectury doctor, I'm a cool doctor. And we reduce that level of the paternalistic power differential between clinician and patient. And I'm learning from example here of the great Professor Mark Nelson himself. You can see his casual dress code. He comes to work in jeans and he has a little relax in the sleep pods on his break. He's going to hate me for putting that picture in. So thank you very much, and I'll take some questions.
Thank you, Joe. We have about 5 minutes for questions. Any questions in the room? I'm just looking out for questions online. And I think there's a comment here about the importance of peer support. Somebody from Namibia saying they still have young children and adolescents living with HIV. Most of them suffer in silence, and once they get to learn about their HIV status, it takes a toll on them. Perhaps we need more programs that are focused on those populations and empower them to face the world despite their status.
Yeah, I couldn't agree more. I think we're going to hear from Eli in a little bit about our child and adolescent approach to HIV. Are we not? Sorry, have I dropped you in there? But yeah, no, absolutely. I think child and adolescent, I mean, we have a small and shrinking population in the UK because our mother-to-child transmission rates are very low. But for these, this group, it's really important to focus on them because adolescents, being a teenager is rubbish anyway, and then you get the discovery that you've got HIV from your parents, and then you hate them, and then they kept it from you, and you don't want to take your tablets as an act of rebellion, and it runs it off problem. But I definitely agree. Like peer support, having somebody who, a role model who can, show that it is possible to live and live well with HIV.
Any questions in the room? I've got another comment from Uganda saying we also need to create more awareness, more so on people with disabilities and also displaced people. So I think it's something that we need to think about throughout the day. Yeah. There's a question at the back. Microphone number 2 is coming to you.
Thank you. My name is Anna Maria Schweitzer. Thank you for the presentation, very interesting. And you shared in the beginning that your colleague called you saying we got one of your patients. And I know it's a tricky question, but what would be some ideas of interventions that we might think about our colleagues in this situation? I know it's difficult to say, well, you've just been judgmental right now, but how can we think about educating our colleagues or finding strategies to prevent future situations like this? Thanks.
I mean, I think showing them a presentation a bit like this and, making people reflect on their own practice and be like, oh, yes, have I done that in the past? Like, starting the conversation. A lot of people don't even examine their own biases, and that, I think, is the first hurdle.
If there are no more questions, Joe, would you mind go sitting at the extreme end?
Thank you.
Well, preparation for the next panel. Our next speaker is Rebecca. I can't pronounce your second name, so I'll just end it, Rebecca. She's going to talk about how would you like to be communicated, how to speak to people, and how do you deal with making mistakes. Yes, please come to front. Oh, are you doing a double act? Oh, I thought as much. So she's doing a double act with Francis, also from Chelsea and Westminster. Just to give you more about Rebecca. Rebecca started a career as a sought-after hairstylist for fashion shoots. Ooh. For the Eurovision Song Contest and celebrity clients. She went on to own her own separate talent model agency, Now Assets, in the 80s and 90s. Since writing her biography in a well-received book, his name is Rebecca. She's now a sought-after public speaker and has spoken at various events all over Europe with THT. Rebecca has roles on the HSE and the 56th District as a peer support worker, HIV awareness campaigner, and Project Bootcamp fundraiser. So Rebecca is the first transgender woman in Ireland and is the first person to hold the Irish passport in their reassigned gender. Her co-partner in the double act is Francis from Chelsea and Westminster. Francis is a specialist registrar in the GUM at Chelsea and Westminster. She currently works within the Trans Plus Gender Dysphoria Service, which provides gender-affirming care integrated with sexual health and HIV. She has spent time working on HIV medicine in England as well as in Malawi. She's currently undertaking a master's degree on gender studies with a focus on the effects of colonization and migration on sexuality, gender identity, and gender roles. Welcome to the stage. Yeah, come to the stage. Oh, here to the mic.
I'm going in behind you, I think.
No, this is fine.
Where?
Just there, on the stand here. Oh, no, here. Do you have slides or are you just talking?
Sorry.
You just talk, that's fine.
We'll both share the mic. Hi everyone, thank you for that introduction. So I'm Frankie or Francis. I'm a doctor based in 50 Dean Street. I'm a specialist doctor in HIV and sexual health, and currently, as Memory said, I'm also working in the trans plus gender affirming service, which provides gender affirming care integrated with HIV care and sexual health. And Rebecca is one of my lovely colleagues. And we're going to have a conversation today. Basically, oh, thanks so much. We're going to have a conversation today. You have that one.
Hello.
Basically talking about stigma in healthcare, what's done well, what's done badly, and kind of using Rebecca, who's very kindly going to be giving us your own experience, both as a patient and as a colleague, so we can kind of really have a well-rounded perception of what's been going on. Rebecca, do you want to do, well, you've been introduced, but do you want to mention a little bit about your kind of your background and your history and your kind of experience with kind of being, because you've been very well known to us for a long time, right?
Yeah.
So.
Hi everybody, it's great to be here. As you heard, my name is Rebecca Talland de Havilland. I'm a trans woman. I transitioned in the 80s. That's how I found out I had AIDS at the time, because it was compulsory to have an AIDS test when you were going for an operation. So I come from white privileged middle class Ireland, so I thought that there was no way I could catch HIV or AIDS or anything like that, because back then we were told it either came from darkest Africa or you had to be gay and into very, very rough sex. And I didn't do any of those things. So when I was told that I had this, it was such a shock to my system, and that I was told I would never be Rebecca, completely Rebecca. And just a very quick synopsis on that, it led to me losing my career, it led me to becoming a heroin addict, a crack addict, sex worker, you name it all, I did it all, you know what I mean? So we can go from there, but that's, and today I work at Chelsea Westminster Hospital as a peer support worker, and I have been I've just made history by being the first trans person in Ireland to get their own television show, so anything is possible. So we'll take it from there, okay?
Thanks, Rebecca. So that's a wonderful overview. So I want to start by asking you, Rebecca, you know, we've seen in Vanessa's slides that there is so much work to do, and there are, you know, some of the perceptions of stigma for people living with HIV, for example, have really not come on that far in 10 years. And I think we're in this little privileged bubble where we talk about HIV all day, or we presume everyone knows what U equals, because we talk about it every day within this. What do you think, kind of from your perspective, we need to be doing kind of better to get this word normalized and to get HIV awareness out there, get people into testing, getting people kind of feeling that this is their problem too?
Yes, very good question. And I heard U equals U. To a lot of us in the business, we know what it means. But to the average person, U equals U can be a very complex. We know, what does it mean? What does it exactly mean? And I was just speaking earlier, and sometimes I've been around a long time, and only in the last kind of maybe 7 years, like literally openly talking about being HIV because of the taboo, because of the stigma, because I'm a trans woman, because I had enough stigma going on in my life. But I still feel kind of, I have to be honest, and that's the one thing I am today, is honest. I get so frustrated because sometimes I feel we're rehashing the same thing over and over and over again. And we were speaking earlier, and I just know myself from speaking, I lead by example, and I've had kind of cis middle-aged women who are now menopausal, not taking the pill anymore, out on the pull again, and us older girls are being pulled by younger guys, you know, I mean, quite easy. And one woman in particular was very conscious that she had been having sex, but never thought she could catch HIV, do you know what I mean? And then listening to me, she was starting a relationship and decided she was going to start it anew and get tested and get him tested. They both got tested and it was negative. And she said the cloud that came from it just changed her whole life. It changed how she saw things, how she went forward. Why aren't we getting people that haven't tested that get tested to talk about how that makes them feel, then we might stop people catching HIV or not looking at it as serious, because sometimes people think, oh, HIV, I couldn't get that. Oh, and loads of times I still get cuts that, have you got AIDS? We have to change. It's like, it's not just one thing that has to change. Everything has to change, because we've been doing this for years. I was diagnosed in 1987. I'm still here. We're still talking about it. People are still catching it. So what do we do to change it? And we do need to change it.
Absolutely.
Yeah.
Thanks, Rebecca. I wanted to talk about kind of your experience specifically. So if we're looking at kind of the intersections of the stigma that you've experienced, you're a trans woman, you're living with HIV, you've had many, many challenges, some of it you've mentioned as well, in growing up in your life as well. How do you, from your perspective, a lot of those things can cause a lot of anticipated stigma, as we were talking about earlier. You go in, to those healthcare settings expecting to have a bad experience. Yeah. What do you think would be some simple steps that we could do from the healthcare point of view that would make people feel more comfortable? Because we know that this is not made up stigma. There's been lots of data, there's been surveys saying 40% of people in the UK who are trans have had a negative experience in healthcare in the last year. This is real. This is not in people's head. They have this anticipated distress about stigma that they're going to experience because it happens and it's happening. What can we do? Just simple steps to make people feel comfortable.
I think as well, a lot of GPs, we have started doing GP training within Dean Street, as you know, scenarios and stuff like that. Also, as well, a trans woman is going to have more stigma around it, because somewhere medically that we haven't been told that if we have HIV and we're on medication and we're taking hormone replacement therapy, that one can counteract the other. So it causes more taboos. Also, I've seen quite a lot of GPs over the years, even up to recently, and if I move address in UK to a different zone, I have to get a new GP. So I have to tell my whole story all over again. I have to start from scratch. So it's really hard. And I think a lot of GPs actually, a GP for me probably would say if they see 200 patients a week, the chances are they're probably seeing maybe at average, if one trans person, maybe even one person that has HIV, there's not enough awareness or training around it. Do you know what I mean? And I remember at one stage there was something, I had some chest problems, and they didn't know whether it was me being on my inhalers that was affecting my. That's extra stress if you're HIV. When you could catch this, you could catch that. I don't know the exact answer. I'm not medical, but I think medical people need to start listening to us. Do you know what I mean? Need to have us a lot more present and not just tokenism. We need to be here. You need to hear our story. It hasn't gone away. I always say HIV is not, it's not fussy. Do you know what I mean? It's still the same thing that we had in the 80s. If I stop taking my medication, I will get AIDS-related illnesses. I will die. It has not gone away. The meds have gotten better. A lot of things have gotten better. But the communication between doctor and patient hasn't. So what we need to do is bring these GPs and patients into a room and let's fight it out. You know what I mean? Let's let people hear us. It's like somebody said something earlier about politicians. Let's get politicians sitting in these seats and listen to what we have to go through with budget change or things like that, or what we might be losing out on. And I'm a white privileged person, so if I'm feeling that, what then is somebody of colour feeling? Do you know what I mean? Or whatever. So, we can do this all day, all night, but we need to get the people like that in here to talk about it. Hope that answers your question.
Very well said. Thanks, Rebecca. I wanted to talk about the kind of, I suppose, the hesitancy from the healthcare point of view, and from not just healthcare, people in general. So, as you say, the training as regards being kind of culturally sensitive, as regards, being proficient in managing people's gender-affirming care and terminology and language, all of these things are not really done at all, and if they're done poorly, so people are there basically ill-prepared. And they almost feel like they have to walk on eggshells. Oh, what if I say the wrong thing? What if I ask the wrong pronoun? What if I offend someone? And therefore, kind of sometimes don't even engage at all. What advice would you give to people who have made mistakes, or who maybe have, for example, misgendered someone or said the wrong thing? What do you think? I suppose your perspective from someone who's been the recipient of care, but also someone who's doing wonderful work in peer support, because none of us are immune to making mistakes.
Yeah, and I suppose I did a conference in Ireland there just the day before yesterday, and it was in a corporate company, and it was about trans and non-binary and pronouns are very new, even for me, and I'm a trans woman, and I would say, I get it wrong, do you know what I mean? We all get it wrong, and it's okay to get it wrong, you know what I mean? But I think it's also down to us that we need, there's a huge lack, whether it's to do with gender, trans, HIV, medical people, that we don't communicate. We don't communicate enough. So we don't know. And I think fear is one of the most crippling things we can have, you know what I mean? And being fearful, rather than face it, you'll run from it. You know, you won't face it. So we do need to do it. But then you've also got to understand, I never thought a day would come. I was on a life support machine in Chelsea and Westminster Hospital 17 years ago. Today I work there. Do you know what I mean? And today I run 2 clinics there. Today I'm standing up here speaking. I think I could have been Sally's sister. Do you know what I mean? Especially kind of going for treatment. All of that, and people kind of thinking, oh, you're just making it up, I was that person to somebody else, but really and truly, I was somebody crying out for help, you know what I mean? Because what people don't tell us, when we are diagnosed with HIV or stuff like that, we're not given a guidebook of how to do this, or where to go, or how do we, oh, by the way, how do I get into a relationship? How do I get somebody to love me? Do you know what I mean? Somebody asked me recently, what's it like? I've never had a proper relationship because of it. And somebody says to me, well, how do people treat you now? I said, well, they run, just not as fast. And, and unless we change that doesn't change. So then you end up with people with HIV, probably not taking their medication all the time, living alone and being lonely living alone. It's fine to live alone, but not to be lonely living alone. So I know at one stage in my kind of time, I thought, what's the point of me taking my meds? This isn't going to go away. I'm told I'm going to have this for life. So for me, I kind of hit the struck button. I'd nearly at one stage would rather have been dead than to live in that stigma and around the way we do get treated.
Completely. Rebecca, I wondered, you mentioned before about, having to retell your story all the time, as in the healthcare setting, and, how, doctors need to be communicating better, not just doctors, everyone in healthcare needs to be communicating better. How would you kind of describe, either from an interaction that actually happened for you, or kind of your ideal kind of scenario, if you were going to be in a healthcare setting, or how would you feel kind of the language, the kind of, ways that people would make you feel comfortable? What would be the kind of the key things that would really kind of, you feel like this person's got my back and they're doing the right thing?
I definitely have one for that. It was going back in around 2012, 2013, I was back living in Ireland. People didn't know I had HIV. I ran out of my medication. I went into denial. I thought it was fine. I looked fine. Eventually I got AIDS-related stuff and was given 18 months to live. I decided to come back to London to get a second opinion from Mark Nelson, and he did tell me that I was pretty ill, but that there was a trial coming out of America that would help me. So I had to live back here, and in doing that, I had made myself homeless here. So I was put back on a track again in a B&B, being misgendered terribly, and then I must have seen social workers, people about getting benefits, people, you know, like about 20 people, and each one I had to retell my story until the Irish in me just said, I'm going to tape this and just press play. You know what I mean? Because you just get so fed up, repeating. And then some GPs are like, kind of like really, oh my God, I've never met somebody like you before. They've misgendered you. Or you get a really kind of hip that think they're hip and say, oh, you're trans, okay, yeah. Yes, some of my best friends are gay, and I go, so are mine. You know? So you get that. Or also as well, you just go in with a headache or a sore stomach or something, you know, and they go through the whole rigmarole. Well, it might be your meds, it could be your hormones, it could be this. And yes, it could be that, but it also could just be a headache. And it's just that stress that you have to go through, you know, that it's, you just, sometimes you just kind of, it does kind of get to a stage, no matter how strong you are, that sometimes when you're dealing with all of that, and as a HIV, but you just think, is this worth it? You know, or when is it going to be right? Because I know what I have. I've learned in this, I've had it decades. But every time I go and speak to somebody who has gone through college, is being paid a fortune for sitting in that chair to tell me I have a headache, and they haven't the first idea of what to do with me. Do you know what I mean? I leave more frustrated than I went in. So it's like that. We need to get these people, politicians, GP, in here. They need to hear. We need to get more of these.
We do.
From across the world, you know what I mean? Telling these stories so that people can hear them.
Absolutely.
You know?
And the representation is just vital. Because,
yeah.
I mean, I think that is one of the biggest things in our battle against stigma, that people say, well, no, that's just certain groups of people, that's whatever. No, this, as you say, HIV is not fussy, it's not particular.
No.
Human beings can get it the same way as any human beings can, irrespective of ethnicity, sexuality, gender identity, and social context. It physically can affect anyone, and you're so right that we do need 1 million of you, if not more.
Yeah, but it also shows how easy, like, people can actually be, you know, can have cop-out. HIV to the world, or to the world as, they consider it a sexual thing, right? We got COVID. Look how quickly we got cures for COVID. Do you know what I mean? Look how quick, because it was dealing with a hierarchy of people and everything. I'm sorry, but we have to look at that. Do you know what I mean? We have to see that that is fact, not fiction.
Completely. We've got about 3 minutes left, and I wondered if we could at this point talk about some of the amazing work that you do in your boot camp with peer support, and how you took that jump from having what you've already described to me before as kind of a lot of internalized stigma against yourself and feeling, oh gosh, I can't tell my story, pressures from external stigma as well, and how you made that jump to being like, yes, I'm going to tell my story, and tell us what you do with your amazing story and the work that you do.
Yeah, there again, it happened, I suppose, around 2013 when I was given a second death sentence, 18 months to live, because I hadn't taken, and this time it was kind of like my fault because I had stopped taking my meds, because I was back in Ireland. And my own self-stigma, I think that's the worst anyone can have. And then kind of getting the second chance, I just thought to myself, I've got to come out of the shadows and talk about this and do something about it. And then I was going to the gender identity clinic for, I just wanted to get something done with my voice. I felt it was too masculine. I just had this thing. And I saw that I was being treated okay when I walked in because I looked more femme, or I looked like what they expected to pass. But there were some didn't fit that criteria for the staff that were working there. And I just thought, what can I do to help here? And because I was a hair and makeup artist, I thought I could help there. And it started there. And then it grew. And then I realised, and I was doing it at Dean Street, then I realised that there was a lot of poverty within the trans community. And then I kind of started getting CVs done. And the reason I did that was because I did that at Terence Higgins Trust did that for me. I didn't have to turn on a computer 5 years ago. And I just thought, I'll do that. And then I got in touch with Kensington Palace, Chelsea Football Club. And before I knew it, I had all these people supporting it. And it grew, and I had a graduation. And then some of my girls started to get jobs. And they weren't sex working anymore. I got some on prep. And it just grew, and it wasn't anything, I'm not trying to be Joan of Arc, believe you me, I'm not. Some of them drive me absolutely crazy. And now I'm doing it in Ireland, you know, and I just feel that sometimes people need a hand up, not necessarily a hand out. If you empower people, you know, trans people and a lot of people of minorities, the government will put us living in areas that aren't good, that we do get crime, we do get beaten up and all that. But if you give somebody a job that they can buy their own clothes, get their own hair, choose where to live, I know that changed my life because now I take my meds every day because I live in a safe, secure place, home. I have a home today. You know, I have 2 dogs today. I have responsibilities. So it's important that I take my meds every day, that I eat properly, that I look after myself. That wasn't the case 5, 6, 7 years ago, you know. I'm also 64. Sorry, I'm 64. It's like, I got a round of applause for that too because most trans women don't even get to live to be my age because they're either murdered, they've taken their own life, or a lot of us don't get to live this age living with HIV. So the moral of the story is we need more education around how we are being treated and how marginalised we are in society, despite us sitting in a hotel today.
Thank you, Rebecca. That was amazing. Thank you.
Can I ask you to move over? Then we'll have a panel discussion and people can then ask you questions. You can leave that mic here. Okay. I would like now to invite Dennis Onyango from the Africa Advocacy Foundation to join the panel. Dennis has over 19 years of experience of grassroots community health. You can come this way. And sit there, or sit here. He's currently a board member of the European Public Health Alliance and is involved in healthcare policy at national and international levels. He has served on a number of advisory boards and working groups, including the EU Civil Society Forum, WHO Regional Coordinating Committee on HIV, Hepatitis, TB, NHS England Clinical Reference Group on PrEP, UK HIV commissioning, amongst others. Dennis' background is in education, policy, public and voluntary sector management. So Dennis, I would like you to sort of give us the aspect of how to communicate in a non-judgmental way from an African perspective, since you work mainly with the African community. I'll just give you like 2 minutes before Luca comes on.
Thank you very much, Memory, and thanks everyone for being here today, for those joining us on site and online. And to my wonderful panelist colleagues for such very insightful discussions. Really, with the communities we work with, who are mainly migrants and Africans, the experiences of stigma and discrimination, particularly in clinical care settings, persist. A number of patients we work with routinely report being dismissed when they ask questions or they have concerns. There are cases of being treated differently, for example, being asked to wait in appointments so that they can be treated probably in more hygienic conditions. That's what they say, they're being told, or protective conditions, which means that HIV is a problem for most clinicians. And that is actually confirmed by a recent survey, I think, by Fast Track Cities, that looked at experiences of care patient experiences in primary care. It's staggering that a lot of clinicians don't have any knowledge about E equals to U, for example, or that 40% of these clinicians surveyed from 3 London hospitals still felt that they can contract HIV by treating someone who's living with HIV. So I think that we need to be, what do we need to do as clinicians? I think that we need to first of all recognize that treatment, HIV care is just not about adherence or putting somebody on treatment. For a lot of people we work with, there are a lot of issues in their lives: housing, poverty, migration. And I think even if you are communicating or doing your clinical duty, I think the question is also around the environment in which you're providing that support. Is your tone right? Are you mindful of this person's, other potential issues in life? We know very well that health ranks very low in the priority of people we work with, mainly because there are life pressures. And recently, for example, we had a case of a young man who had a father who was dying at home. We diagnosed him with HIV. He was desperate to go back home and he could not. He wants an air ticket, but he's not working, he's undocumented. And so we were taking him for treatment. And when we accompanied him there, he didn't feel that he was treated very well. And the clinic had to come back to us. I think that first of all, we need to be able to appreciate, again, what community organizations such as ours provide, because I think that for a long time, a lot of clinicians, there's excellent work going on, and of course we appreciate our clinical colleagues who are working on HIV, but I think that if you look at general experiences in primary care, there's that lack of understanding, and I think that the role of organizations such as us who are providing support to patients should be appreciated and actually tapped, because there's an element of issues of trust. There's the issue around how people, perceive services. There are a lot of unconscious biases. One in 16 people have actually experienced discrimination and stigma in clinical settings amongst HIV patients, for example, in London. So I think I don't want to go too much. If there's any questions, you can ask, but I just think that, the issue of communication, the issue of being able to understand, have trauma-informed, perspectives when you're treating somebody, appreciating cultural, faith and language barriers, looking at issues of immigration. We have a lot of hostility towards migrants, which is actually driving a lot of lots to follow-ups. So all these are very important, and we are here as community organizations. If you're not very sure or you need additional support, we know times that are provided for patient care, quite limited consultations, but we have a lot of resources in the community, and I think some of these conversations, we can actually do them very well. So let's work together, and let's try and see that everyone has good experience of care in HIV.
Thank you, Dennis. Last by means no least to join the panel is Luca Stevenson from the European Sex Workers' Rights Alliance from Belgium. Luca is a male sex worker and operations officer at the European Sex Workers' Rights Alliance. Luca has worked extensively across Europe with sex workers from various backgrounds, including migrant and LGBT sex workers. He is also currently responsible for Mission for Jasmine, a project of Medicines du Monde France, which aims to address and reduce stigma and violence against sex workers, and sits on the board of directors of the global network of sex work projects and the Red Umbrella Fund. Welcome, Luca.
Thank you.
So, Luca, while you settle down, I'd also like to invite you to just share your experience of stigma and how people should be communicated. How to communicate with in a non-judgmental way. I can't speak anymore. I was up at 3 a.m. In your area of work.
Well, thank you very much for having me and representing sex workers as well on this panel. Lots of things have been said. I think for us, sex workers, one of the main issues we are facing is that the first impact of stigma is we are seen as a monolithic identity. So if you think of sex work, usually the first idea you have is usually a cis woman walking in the street, possibly using drugs, which do exist and are a big part of our community. But actually there are many, many forms of sex work and identities within sex work. So we heard, from Rebecca and from others earlier that many different people work in the sex industry, whether they are trans women, trans men as well, which are often completely underrepresented, cis male sex workers, etc. And the needs vary as well. So I think the first impact of stigma is when you say you're sex work, you're definitely associated with specific issues that might not be your issues. So I think there's a lot of work to be done. We were talking earlier about doing training for healthcare professionals. But I feel one of the main issues is that you cannot really address stigma against marginalized communities if you don't do change at the structural and policy levels. So Vanessa was explaining at the beginning that stigma goes from like, internalized stigma to interpersonal to structural to policy level. And if you look at the situation in the UK, for example, in Scotland even, where I live in Scotland for many years, the definition of prostitution in Scotland is violence against women. And if you don't agree with this definition, you cannot access funding. So we had like a really good project led by sex workers doing services for sex workers in Scotland, and they lost their funding because they disagree with this definition, which is an extremely stigmatizing definition. Prostitution is not violence. Sex work is work and is recognized as work by the World Health Organization and by sex workers themselves. That doesn't mean there is no violence in the sex industry. There is a violence in the sex industry, and that's why we need to work in collaboration with sex workers in order to address some of the key issues we are facing. So for me, it's always, there can be a lot that can be done. There could be lots of training. I was really relating to like what Rebecca was saying, like, personally, I'm also extremely tired of telling my own stories. You know, I'm sitting here, I'm like, yeah, should I tell about like when I arrived in London and I was homeless and I was like, going to Homerton and, and there was actually lots of like really good relation with like, we talk like there's lots to be done, but already a lot is being done. Like we also have to like recognize that in the UK and many countries, there's already like a lot being done to address some of the stigmatizing attitudes. We're not like we were maybe like 40 years ago, still a lot needs to be done. But I think for us, like we can't really address stigma unless we address structural factors that impact our communities. So sure, let's do training with healthcare professionals to address the stigma against trans communities, against sex workers, against migrants, against people using drugs. But as long as like sex workers and other communities are not involved in the development of this training, are not supported, including with funding, then we're not going to have a long-term change. So my own personal thing, I wouldn't talk about my own experience of stigma. I mean, I can during the break if you want to hear some sad stories. But I think it's more important to like really reflect what can you do at your own level to make these changes happen. Because there is a global call for, from WHO, from UNAIDS, etc., to address like these structural issues. And what I'm talking is not just vague, like, I work now mostly at the European level, and currently at the European Parliament, there is a development of a prostitution report. Who is writing this report? Definitely not us. It's people who are committed to abolish prostitution through criminalization. So they are calling for more criminalization of sex work, which we know will increase the discrimination and stigma that we face. And that is not just theoretical. Like if you look in Ireland, for example, Ireland criminalized clients of sex workers in order to abolish prostitution. And this directly led to an increase of violence against sex workers, in particular most marginalized sex workers like trans sex workers and migrant sex workers. So we know there is a really clear link between legal frameworks, criminalization, stigma, and discrimination. And this needs to be addressed collectively. So my main point would be that, we do need, as sex workers, we need specific services. I think it's very important that each main cities and actually like rural areas have specific services for sex workers where sex workers can come and talk openly about some of the issues they face. Some sex workers want to stop sex work. Some sex workers want to get support in order to do it more safely. But in particular, what we need is like a general training and general addressing discrimination and stigma that sex workers face in all health services and HIV services. So it's both developing proper services in collaboration with the community, with sex workers as peer workers, etc., but also addressing stigma that, yes, as Rebecca was saying, so I keep saying Rebecca because I feel like we're relating a lot. If a sex worker comes and say, I have a mental health issue, for example, the direct response from the mental health professional is not, oh, it's because of sex work. Like that's one of the things that would happen to me. I would go to a service and be like, I'm dealing with anxiety, with like, PTSD, for example, and the first answer would be like, oh, it's because you're selling sex. The easy answer is like you have to stop selling sex. It's like that doesn't answer any of my questions. What you need to address is like the quite intersecting issues that I'm dealing with as a sex worker, but also as a survivor of violence, as a migrant, as somebody who faces homelessness and mental health issues, which is much more complex than trying to find the easy solution with like, oh, the issue is sex work. Stop sex work and you'll be fine. Most of the time, people have very intersecting issues, and this is how we need to unpack and understand stigma and discrimination. Thank you.
Thank you.
Thank you, Luca. We've heard from a very diverse speakers, and we now have a chance to ask any of our speakers any questions. And we're now also open on the online forum, which I'm keeping an eye on. I mean, there's a lot of comments, very good comments from Rebecca's experience, From Joe's presentation, from everyone's presentation, everyone's just saying, you know, the main issue is that the people we actually need to reach are unreachable, and how do we work on that? So the floor is open for questions. There was a question on microphone 1. Thank you, Jeff.
Yeah, good afternoon. Thank you for your speeches. I just want to ask, I don't know, any one of you can answer the question. We know that when HIV came out at the early stages, there was strong campaign, and that changed the mentality and the views, formed the views around people living with HIV, and that view still sustains up to today. But we've seen medication, treatment advances, we've seen U equals U coming out, but that has not received the kind of publicity that occurred in the past. And that is the reason why stigma is still a problem. Because I think that if we begin to project a narrative of the advances in treatment and the efficacious nature of U equals U, I think that would change the mentalities. So I don't know if there is any kind of strategy, you know, in a continental basis that would be able to project that narrative. Because if you ask someone on the street what is U equals, they don't know, but they have an historic understanding of what HIV is, and that has not changed. But yet there is advances within the HIV community and within the healthcare settings. We know all these advances, but people out there are not aware of it. And we're talking about stigma, fighting stigma. That means we're fighting it on a superficial level. If we need to fight it, then we have to project the message and let everybody become aware of it. And that's I don't know if there's any kind of interventions in that area.
Who would like to go first?
I can say something. I agree with you totally, and because I'd say it was about 4 years ago when I was working at Terence Higgins Trust, and we used to do outreach in Soho. So we did certain different campaigns, and one of them, it was very in its early days, I think, if I'm right, U equals U. And the guy I was working with kind of got the U equals U slogan and campaign thing. I didn't get it as much, but then there was the Can't Pass It On campaign. And that kind of registered a lot more with me, that I was able to, when going around bars, you know, like even saying to some girl, you know, that was at a bar, well, what does U equals U mean? And then you say Can't Pass It On. And if you say Can't Pass It On, well, if you're HIV, you're on your medication, you're undetectable, and if you were pregnant, you can't pass it on to your unborn baby. That makes sense, and you can see the penny dropping with that. But, and I'm being quite honest here, for ages it took me a long time as well to kind of sell the U equals U campaign, because I found it, for me, I don't know whether it's because I'm blonde, but I found it just tricky to get out there for some reason. And I do know that since that, a lot of people say, yeah, it sounds like it should be easy. And I think it's very catchphrasy, and it works, it looks good. But I don't necessarily know that that message gets across as, to me, what the Can't Pass It On campaign does.
I will say, I think one thing that has been helpful, certainly for targeting the MSM community, is use of social media and also use of dating and sex hookup apps. So Grindr, we all love to hate it, but they have got a big thing about you know, putting people's HIV status, and they have a little info button about what U equals U is and how to get PrEP and links to more information. So how do we target people who aren't on these apps is the next big question. Perhaps, I mean, faith leaders, I think, you know, targeting sort of the Black African, like, religious and other religious communities. How do we get them on board?
Dennis?
So that's a good question. I think personally, especially we have to start with the community of HIV. You know, I've just referred to a survey that was done where in 3 major London hospitals, where 80% of clinical staff there did not know about U equals to U. I think we need to start from the basics, and I think Gary will talk about the work they're doing with the fast track cities, of which public awareness is one of them. But I was just speaking to one of our patients last time who is looking to date, And she was saying that she feels it's unfair for her, somebody who's living with HIV, to be the onus to be on her to prove that she's not infectious. And I think that this is something that we really need to change. I think the conversation needs to move from HIV patients and the HIV community to the general public. And how we get that is to use all tools available, really, whether it's our private social networks, our WhatsApp groups, our families. We need to talk about it.
Okay, we have 2 questions from the microphone. I see microphone 1 and then followed by microphone 2. Go ahead, sir.
Hi, I'm Glenn from Eyes Open. It's actually an area which we work in. We're responsible for 4 NHS trusts pulling together their sexual health campaigns. Last year we did a U equals U campaign, and that followed up from a U equals U campaign the year before. And of course we are now living in a society which is very celebrity led. In terms of statistics, 2 years ago, 50,000 people across 4 counties watched information related to U equals U. We involved a celebrity last year from It's a Sin, and 2.3 million people clicked on our pages. Unfortunately, the funding side goes along with everything else, trying to justify to a funder that they should pay for a celebrity is pretty much a brick wall, and we find ourselves yet again now this year where we've had to delay our campaign for another year, just so as we can try to source funding for that. On a separate note, can I just say, Joe, you're a breath of fresh air. I got diagnosed at the Kobler Centre 28 years ago, and it was a different world back then. In fact, I found out I was HIV 30 years ago when I was, I'd been treated for hepatitis, but I had to go along for the whole officialdom, and I couldn't cope with the stigma. I ran away from it. My whole life has been revolved around pride work. I've been the chair of many prides, but I've never tackled the subject of HIV. And it took the death of my doctor, Dr. Martin Fisher, rest in peace. What a brilliant man. He kept me alive all of these years. But it took his death for me to realize that it's not all doom and gloom, and that it's not all about the stigma, and that you can do good even from behind the scenes.
Thank you.
Thank you. Microphone 2.
Yeah. Hello. Thank you for the presentations. My question to you is when you move into Scotland. I'm really excited by the U equals U message, and I came to the party late because I was very much untransmittable is not a word in English. And I think after 2 years of COVID and untransmissible, it was really encouraging to hear Kevin Fenton, Professor Kevin Fenton, at yet another talk shop, say undetectable means uninfectious. I'd never heard someone so senior in the medical model, at senior level in public health, speak about uninfectious. And there's been a whole range of reasons why that hasn't happened. I guess for me, can't pass it on. I've always found it really challenging, passing it on, getting it, catching it.
Yes.
Because the language suggests inequity. If I'm passing it to you, it means I've got more agency, you have to catch it. And I think can't pass it on. Well, that means who can pass it on, then how do you pass it on? I think really the language about transmission and acquisition, people go, that's too complicated. Well, teach people. You know, we're dumbing down language to such an extent that the reading age of your average audience is 14. You know, I think after the COVID revolution, we've all been in the fridge for 2 years, people are very, very capable of using transmit and acquire viruses. I just think the language is much more equitable. So I really invite this fora to kind of adopt that as a mechanism going forward. The language of transmission and acquisition is equal, passed across an equal platform. Nobody's got more agency than somebody else. People do not transmit viruses maliciously for the most part. If they are, there's something going on with their psychology or mental health. So I really invite the language of acquisition and transmission to be more meaningfully considered.
Thank you, Alistair. I agree. Language is very important. Language is very important in everything that we do, and it needs to be considered and taught to everyone in the healthcare system. Microphone.
Thank you so much. I just want to add a comment to Joe's comment about faith work and faith communities. I lead on one of the Fast Track Cities project, on FaithWorks in London. And clearly there is a lot of discrimination and stigma in the faith communities. My experience on the project, when you talk to faith leaders about HIV, they will say, that's not my area. So what we've done right on, is integrating HIV and other conditions in the faith communities. So this is what we do. You go out, you tell a faith leader, people have HIV, people have diabetes, people have hypertension, and people have also had COVID. So we'd want to bring a service to the faith community, and it is a holistic approach to everything. And that way, we can then talk about sexual health and HIV. And clearly, because of the stigma associated with HIV, the service may not be received. But if you add it or you integrate something else, then everybody will come and receive the service. I'm happy to let you know that over 50% of the faith communities we've approached, just integrating HIV and other services, they've been able to open the door. And we know that a number of people who have so many conditions will run to their faith leaders. Many of us will not go to the hospital per se, but at one point, you want to go to your church. And many people congregate with others. So it is a very, very important aspect when you're addressing HIV, especially in the faith communities. Thank you so much.
Thank you.
Thank you.
Thank you.
I wanted to just add to that. Thank you so much for saying that. We talked about social media, we've talked about faith groups. I think kind of the overall summary of what I say is that there isn't one size fits all. We can, in Dean Street, we put up campaigns when it's Prep Awareness Week in GAY and in Heaven, and we have great responses in those communities. But that's really not everyone's communities. We need to be going into different spaces. We need to be going to faith groups. We saw in COVID when there was so much distrust in healthcare that people use leaders in different communities to get them to engage. If we're not actively going in those spaces, and we're just going in spaces that we know or are familiar or convenient or we've had success in the past, we're just repeating the same thing again and again. And actually where we need to go is where people are invisible, people who aren't coming to see us, people who aren't coming to get tested, people who don't think that things are relevant to them. Rebecca mentioned a lady who was dating kind of in her 50s and thought, well, no, that's not something that's relevant to me. Why doesn't that person think it's relevant to them? It's relevant to everyone. And if we keep this as niche as just people who work in community groups and work in healthcare to do with HIV, not GPs, not other specialities in our colleagues, and they aren't saying the same thing as us, it won't change. So I think we just need to make sure that we're flexible and we're just thinking outside the box and not just doing our perspective, but asking people who aren't coming to our services, why not?
And I would like to say too, I agree with that. And also as well, it's great that we're actually doing this here today and it's not World AIDS Day, where we see an awful lot of stuff just done immediately coming up to World AIDS Day or around it. And I just think, I always say to people, I live with HIV every day of the week, every day of the year, and we do need to spread it out more. And I think that that's sometimes why we do get people kind of still taboo to talk about it, because it's a bit like your birthday is once a year, you know what I mean? Christmas Day is once a year, and now almost like World AIDS Day kind of kicks off Christmas, so we need to kind of get HIV, more of these going, more through the year and stuff like that, because I don't want to use the word normalizes, but maybe it needs to be normalized more, that people see it not so much as a taboo, especially people in religious orders and community and people like that. I think we need to do more of it, you know what I mean? And I'm beginning to see it happen more every year, that we're doing it not just around World AIDS Day and the like. I think that's important.
Thank you, Rebecca. Any last words, Luca?
No, just maybe briefly, we often talk about our communities as hard to reach, which, for us seems a bit weird because like we're right here and like, you know, for sex workers, for example, our clients can find us so easily. So why is it easy for like our clients or the police to find us, but like health services find it much harder? And I think it is because of internalized stigma and because we're simply not a priority. I feel like each of the key population, whether like trans community, MSM, people using drugs and sex workers, you know, like without making a competition amongst our communities, like sex workers often feel like we are basically like not really important in this fight, partly because of internalized stigma. And I sometimes like stigma within like healthcare professionals or funders or governments, etc. But one of like you were saying, for example, about Grindr, you know, sex workers, the majority of sex workers in the UK use one platform. I don't know if anyone knows it, that would out you as a sex worker or client or an ally. So most sex workers use this one platform. There might be like 80,000 sex workers there, but there's no intervention made with this platform to reach out to sex workers there. So Adult Work is a platform, in case you don't know, you can check it out. Like, you know, there's 80,000 sex workers like advertising there. Why is there no intervention done with this platform in order to reach sex workers? The issue is that this platform technically is criminalized. You know, like people who run this platform are third parties, they profit from prostitution, therefore they could be charged for third party for pimping under the same laws that are criminalizing anyone who profit from the sex industry. So for us, there is really like this intersection on how criminalization actually also act as an obstacle to outreach, to prevention, etc. So that's why for us it's really intertwined, this issue around like discrimination and criminalization. The same is like, you know, if Grindr was criminalized because they would act as like, you know, a third party, we wouldn't be able to like use and collaborate with them in order to do this outreach project. So for us, this is really important to like work in partnership with sex work communities in order to like bring this message forward and have this like community empowerment that is essential to address stigma. Thank you.
Thank you, Luca. Oh, there's a question from microphone 2.
Marielle Maya, Medical Director for Vives Care. It's just a comment I would like to share with you because when I was a student at hospital, we have that key expert completely engaged into HIV, spending all their time into it. The new generation at hospital, at least in France, at least in Paris, let's say that way, they are less and less engaged in HIV. HIV is not anymore a future option for them. They are much more involved in infectious disease in general, and HIV is simply part of it. And that's something I think, coming back to what you say about the role of the HCPs and the nurses, this community in adding stigma to the people. So we are having less and less young physicians interested in HIV, and now the proposition is not to have a department dedicated to HIV, but much more department dedicated to infectious disease in general. It was just a comment I wanted to share to you.
Thank you.
Yeah, I think that's really important, actually. So the UK and Ireland and Australia are unique in that we have a specified training pathway for genitourinary medicine. So we do integrated sexual health, HIV, family planning and contraception. And as you say, most other places, including most of Europe, it's HIV is done by infectious disease, and then everything else is done by either primary care or sort of gynecology or dermatology. My favourite joke about this, what's the difference between infectious diseases and gum? ID is Doctors Without Borders, and gum is Doctors Without Boundaries. But because we have that kind of community activist, patient-centered approach, most of us are, serving the community that we belong to. I think we can, that model, I really like it because it provides better care, I would think, for our HIV cohort.
Thank you. We'll take one last question before our tea break so we can wrap up. Thank you. Microphone number 1.
Thank you, Katie Darley. I'm a consultant physician in Switzerland. I just wanted to pick up on something that Lucas said, and also Joe, I think, talking about the medical profession being paternalistic. And it's one thing being on the ground and relating with the patient, but it's a completely different thing to give people a voice. And what I love about Dean Street, like Rebecca, I hear this with other people as well, that you walk into the clinic, you see a need, and then you roll up your sleeves and you run with it. And one thing that I've encountered in the medical profession is the lack of somebody within the community who can run with a particular project. And one of the big barriers is other doctors saying, oh no, you can't ask them because they've had a really difficult time. I think it'll be too much for them. And I would say, you don't know that it's going to be too much for them unless you invite them to take part. And in my experience, when there's been a particular project, asking somebody who on paper might not particularly want to be involved, or who's a little bit shy, or who just hasn't been given a voice, when you present that to them, I've not yet had somebody who doesn't actively want to take part. And so I'd say one aspect of paternalism in medicine is to remove the need to be the voice when actually the people from the community can be the voice themselves.
Okay. Thank you. I just want to acknowledge and thank all the speakers for this panel, and also acknowledge our virtual viewers. There have been very positive comments, people saying, you know, Luca and Rebecca, keep sharing your stories to keep fighting stigma. You need to be seen, you need to be heard. And there's also a comment about U equals U, that it needs to start with people living with HIV so that we can be sure about what we are talking about. We know what we are talking about. So I think it's been a very engaging discussion amongst my talented panelists and speakers. So we now have a tea break of 20 minutes. So we need to be back at 10 past. Is it? Yeah, 10 past.
Thank you.